the story of the development of Gallstone Ileus, which is a uncommon but a important cause of intestinal obstruction. There are three parts in the story. Firstly, you need to have cholecystitis and inflammation. Second part of the story would be development of a fistula, typically cholecystoduodenal fistula. And third part is mechanical obstruction, mechanical intestinal obstruction. I'm going to simplify all these three in a while. And by the way, the name is a misnomer, Gallstone Ileus, because Ileus basically means a functional obstruction, non-mechanical obstruction. But in this case, we actually get a mechanical obstruction of the intestine, particularly small intestine, caused by the gallstone. So a better name could have been gallstone-induced intestinal obstruction. But anyway, that's the part, that's life. You have to bear with that the name is Gallstone Ileus, but please remember that name is quite confusing in that sense. So firstly, let's start with this, that why we need to know about Gallstone Ileus. We need to know about Gallstone Ileus because it's a notable cause of intestinal obstruction. It's mechanical intestinal obstruction caused by the gallstone, which comes from the biliary system and gets stuck in particular in the ileum in the small intestine. So let's start with some basics, and I move to the whiteboard to explain some basic things. First, we need to understand what is intestinal obstruction. The idea of intestinal obstruction is quite simple. The GIT is nothing but some lot of tubes and sacs which are connected with each other from the mouth to anus. And if we look at this, the basic aim of these tubes, like bowel, like intestine, is to take the luminal content in a unidirectional way from A to B. That should move to A to B. That is the basic purpose. But if in any condition there is any interruption, of this luminar content, that means there's any interruption, an impediment, in obstruction in the flow of this intraluminal content from point A to point B, that condition is known as intestinal obstruction. So intestinal obstruction is a condition where there is an obstruction or impediment or impairment in the movement of the intraluminal contents. And it could be due to some mechanical causes, it could be due to some functional causes. So mechanical cause is also known as dynamic, and the functional cause is called adynamic. So if I go to that concept and try to write it down, let me clear this. So intestinal obstruction, I think you know these basics, that there are dynamic and adynamic. There are two subtypes. Dynamic is also called mechanical obstruction. So there is dynamic or mechanical obstruction. Mechanical obstruction means there is a mass, there could be some condition like stricture, or there could be adhesion or band formation, there could be bezoar, there could be gallstone. This is also a cause of mechanical obstruction. So in the case of mechanical obstruction, there is a mechanical obstruction. Mechanically, it is obstructed, the movement, the peristaltic movement is obstructed. And that results in the flow of the intraluminal content. That is called dynamic or mechanical obstruction. The other side, if I do like this, the other side, there is another type of obstruction is there that is possible, that is called functional obstruction or adynamic. Mostly it's due to failure of peristalsis. Like ileus, post-surgical ileus, we get that. Example is ileus. So that's why I was telling at the beginning that the name is misnomer, because here in Gallstone Ileus, the obstruction is due to mechanical obstruction. It's not a functional obstruction. Functional obstruction means there is no mass as such, there's no mechanical obstruction as such, but there is failure in the peristalsis, and that is the resulting in the development of the intestinal obstruction. Now, if I look at the dynamic or mechanical obstruction, there are three subtypes. One is intraluminal mechanical obstruction, another is intramural, another is extramural. That idea is also very simple. That means this is a part of the intestine. Intestine is a wall. So if the mass or the cause of the obstruction is there, cause of the mechanical obstruction is inside the lumen, like for example in Gallstone Ileus would be inside the lumen, that would be called intraluminal because it is inside the lumen. If the mass is within the wall, because the word mural means wall, the word mural means wall. I think you have heard the term mural, thrombus, mural painting, that means wall painting. So the word mural means wall. So intramural means inside the wall. So if the cause of obstruction is inside the wall, and that is resulting in the development of the obstruction, it could be a stricture, it could be a tumor mass, that is inside the wall. That is called intramural. Extramural means that is outside of the wall, outside of the lumen. So something which is causing obstruction from the outside, compressing this intestine, part of the intestine segment, and causing obstruction. So in simple words, I am again repeating what I told, that intestinal obstruction is a condition where there is impairment or obstruction or impediment in the flow of the interluminal contents. It could be due to some mechanical obstruction related causes, which we call dynamic intestinal obstruction, or could be due to some functional causes where there is a failure of peristalsis, like for example, ileus, which is commonly seen after surgery. Could be drug induced, could be associated with dyselectrolemia, other condition. That is, I'm talking about the functional obstruction. Now, mechanical obstruction is, the causes are many of mechanical obstructions, like intersusception, volvulus, hernias, Band's adhesion, bezoars. There could be some ascaris lumbricoides, that means some parasitic infestation, foreign bodies. So these are all cancers, malignancies. These all could result in the mechanical intestinal obstruction. And those causes are further subdivided into three groups. Intraluminal. If the cause of the obstruction, mechanical obstruction, is inside the lumen, inside luminal. If it is inside the mural, inside the wall, because you know that there's a wall of the tube, the tube of the bowel. So if there's a cause of obstruction is inside the wall, that's intramural. And extramural is that is outside and causing compression of that segment. So this is a basic idea. Now our topic of the discussion is Gallstone Ileus, where the gallstone gets impacted inside the lumen, particularly in the ileum, the distal segment of the ileum. And that's why it's a cause of intraluminal mechanical obstruction. So the point which I'm trying to highlight is this, that Gallstone Ileus this is the first concept that is a misnomer. It's an inappropriate name which misguides you basically, because it's not an ileus. When you use the term ileus in the context of intestinal obstruction, basically means functional obstruction. There is no mechanical obstruction, functional obstruction due to failure of peristalsis. But Gallstone Ileus is caused due to mechanical obstruction by a gallstone which instead of staying in the biliary system, enters into the enteric system, enters into the intestine and gets stuck in the distal ileum, causing obstruction in the flow of the interluminal contents. So that's why it's a cause of mechanical obstruction. So it's a cause of mechanical or dynamic intestinal obstruction. Next, I'm going to explain that how it developed, those 3 steps in the story I'm going to do after this. So its more appropriate name would have been gallstone induced mechanical intestinal obstruction. If we think in this way, then it's more appropriate. So now we'll go and try to understand that why and how a gallstone, rather than staying in the gallbladder in a patient with cholelithiasis, how it comes into the intestine and causes mechanical intestinal obstruction. That is our next objective in this InstaLecture, to try to understand that. So let me clear all these things first. So when I think of Gallstone Ileus, I think as a 3-step process, as I mentioned. Firstly, there will be an episodes of acute cholecystitis. You need some inflammation. Why you need some inflammation? Because these recurrent episodes of inflammation, they would cause some kind of adhesions between biliary system and enteric system. That means particularly, usually adhesion is caused between gallbladder and the duodenum because they are closer, anatomically closer to each other. So, and ultimately when they adhere to each other, they adhere. Now these gallstones which are there, if it is quite big, these gallstones are there, they usually causes a kind of pressure necrosis, and these gallstones, they actually causes erosion and they enter inside the intestine. That's the idea. That means there's an erosion there, and these gallstones, they come into the intestinal lumen. So how it happens? It happens by formation of a fistula. So this is the first part of the story which I was mentioning, that an acute cholecystitis is required. Second part of the story in the development of this would be a formation of fistula. I'm going to write it down here. So you need the second part of the story, you need a fistula formation. Cholecystoenteric fistula. That means a fistula, and you know fistula means abnormal communication between 2 epithelialized surface. So this abnormal communication is created between abnormal channel created between the intestine, particularly the small intestine, and the gallbladder, biliary system. And intestine. And particularly this fistula occurs cholecystoduodenal fistula, which you see more commonly, particularly with duodenum. So now there is a grand entry of the gallstone from the biliary system into the enteric system. This is the part 2 of the story, of the development of this. Now let's move to the part 3 of the story. Part 3 of the story is this, that if the stone is quite small, then they can pass easily. But if the size of the stone is more than 2 centimeters, particularly they have seen in a study that they are more than 2.5 centimeters, majority of cases, they usually are prone to cause obstruction. They usually get stuck. The stones usually get obstruct the distal ileum. They get stuck there. Why in distal ileum? Because ileum is the narrowest part of the bowel. That is the idea. So that's why they get stuck there. And by the way, I hope you are already aware that 80% of the mechanical intestinal obstruction, they are seen in the small intestine. Why they are seen in the small intestine? Again, the same concept, because small intestine has smaller lumen, smaller diameter. And that's why the majority of the mechanical intestinal obstruction, they are seen in the small intestine. This is another concept that you should keep in mind. Majority, 80% of mechanical intestinal obstruction occurs in small intestine. And the name gives you a hint, clue, because small intestine has smaller diameter. So if it has a smaller diameter, compared to the large intestine. So that's why out of 5 cases, 4 cases of intestinal obstruction, they are usually seen in small intestine. Large intestinal obstruction also can occur, particularly due to cancers and particularly in the sigmoid colon. Again, because the sigmoid colon has the narrowest diameter in the colon. That's the idea. So same concept there, that if the narrowing of the lumen is there, that would make you prone, vulnerable for intestinal obstruction, particularly with the mechanical intestinal obstruction. So now we again come back to the topic we're discussing, that there are 3-step process that Gallstone Ileus, that there would be episodes of inflammation, acute cholecystitis. This is the step number 1, which I was talking. So this is the step number 1, acute cholecystitis. This is the step number 2, and this is the step number 3. So firstly, there will be acute inflammation, acute cholecystitis, that obviously after inflammation, there will be sticky surface formation. So biliary and enteric system, they would adhere to each other. That's necessary. In the step 2, now through this adhere system, because these systems are now closer to each other, could through the process of necrosis, the erosion, the gallstone from the gallbladder, from the biliary system can move into intestine, particularly by the formation of a fistula. Which fistula? Cholecystoduodenal fistula. Cholecystoenteric fistula, particularly cholecystoduodenal fistula. What is fistula? Fistula is an abnormal communication or channel between two epithelial surfaces. So this abnormal channel, this cholecystoduodenal fistula, creates an abnormal communication between the biliary system and the duodenum. And through that channel, gallbladder, which is supposed to be in the biliary system, supposed to be in the gallstone, which was there in the patient of the cholelithiasis, that would come and get entry into the enteric system. Now, depending on the size, if the size is particularly more than 2 centimeters, particularly more than 2.5 centimeters, then it would be lodged and stuck at the distal end of the ileum. Why ileum? Because this is the narrowest part of the bowel. And that would cause a mechanical intestinal obstruction. And this condition we call Gallstone Ileus, which I mentioned is a misnomer. Ideally, it should have been called gallstone-induced mechanical obstruction, because ileus, in the context of the intestinal obstruction, means non-mechanical obstruction. That's why it's a misnomer. I mentioned. So the next thing is that who would be a typical patient? What would be the patient profile of the gallstone ileus? That is the next thing we need to discuss. So typical patient profile of the gallstone ileus. And by the way, gallstone ileus, though it's uncommon, but associated with significant morbidity and mortality. Particularly, they are more common in elderly females. Elderly females who have a past history, obviously, of cholelithiasis, because to have gallstone ileus, you need to have gallstone. So obviously, that patient should have cholelithiasis, and also they should have episodes of acute cholecystitis. So usually in their 60s, the late female who has developed earlier a cholecystitis, earlier episodes of cholecystitis, cholelithiasis, but often they are not treated or ignored, and the stone become quite big and eroded the system, created fistula. A lot of things is happening in between. So there will be a lag period in between. And so it will be seen in an elderly female who will be presenting with a episodic subacute intestinal obstruction. So typically this one, they say episodic subacute intestinal obstruction. And usually it is associated with a tumbling movement of the stone, this, because the stone is coming from the duodenum to jejunum and to the ileum. Most of the cases, the the stone gets impacted in the ileum, but also can occur in the jejunum after ileum. It's also been seen. And another interesting aspect about the gallstone ileus that it has also been reported in a patient of Crohn's disease. That is the thing you need to keep in. So gallstone ileus, these features were first, there were classic 3 features which are noted radiologically by Dr. Riegler in 1941. And he named Riegler's sign or Riegler's triad. So there is an interesting Riegler's triad there, which is associated with this, which was first noted by Dr. Riegler in 1941, almost 8 years back. And those features are that there would be a gallstone in an ectopic location. Ectopic means not in normal site, because gallstone is not, ileum or intestine is not a normal site for gallstone. There would be pneumobilia. Why pneumobilia? Pneumobilia means that will be air in the biliary system. Pneumo means air, like pneumothorax. So why? Because there is an abnormal channel or communication has been created between intestine and the biliary system. So the air can enter there. That's the idea of the pneumobilia. And obviously there will be a presence of mechanical intestinal obstruction patient. So this is seen in the plain radiography, but currently plain radiography is also appreciated, but also better imaging system like abdominal CT scan is considered even better for the diagnosis of this gallstone ileus. And ultimately, if it is presenting with an acute intestinal obstruction, ultimately it will be surgery, enterolithotomy need to be done, that the removal of the stone would be required after proper resuscitation. That is the basic idea of this. Now, the context of this that you need to understand that gallstone ileus in a nutshell, that gallstone ileus is more or less a condition of the females, elderly females. Why? Because these elderly females, you know that those if female fertile 40s, they usually develop gallstone. And the gallstone, they become big, they create fistula, and after 10, 20 years, typically they create all these stories happening inside the body of that lady. That means there's formation of the cholecystitis, and obviously that needs some kind of negligence, because obviously if you treat it promptly, if you take care, these things might not develop gallstone ileus. But often that the person has a history, preceding history of the cholecystitis or gallstone, and that would proceed to the development of all this. That means recurrent acute cholecystitis, which would cause an adhesion in the surrounding structures of the biliary system, followed by formation of a fistula between the biliary system and the enteric system. small intestine, particularly the duodenum, cholecystoenteric fistula, cholecystoduodenal fistula. Through that fistula, through that abnormal communication, this enters there and gets stuck in the distal ileum, because ileum is the narrowest side, and can present with the episodic, subacute typically, could be acute also some cases, mechanical obstruction. That is the and episodic, that is another feature. Sometimes it could be chronic also, that be episodic features are there in this. So all possible, three things are possible actually: episodic, acute, chronic, subacute intestinal obstruction is possible, and ultimately leads to form of mechanical intestinal obstruction. That is the thing you need to know. So in a nutshell, Gallstone Ileus, as I mentioned, is a misnomer. It's a mechanical intestinal obstruction. Typically, the gallstone gets impacted in the ileum because it is the narrowest part, and it requires three-step process: gallstone formation, acute cholecystitis, followed by fistula adhesion, followed by fistula, cholecystoduodenal fistula, abnormal communication between biliary and enteric system. Gallstone enters inside the enteric system in the intestine, gets stuck into the narrowest part of the lumen small intestine, that is the ileum, and presents with some episodic intestinal obstruction, particularly common in the elderly females who had a past or preceding previous history of the gallstone and repeated episodes of acute cholecystitis. And regular triad, I mentioned, this is associated with this. These are the key concepts that you need to keep in mind about the Gallstone Ileus. And also I briefly revised the key concept of the intestinal obstruction and the causes here, because intestinal obstruction could be mechanical or could be functional, and this one, and mechanical could be intraluminal, intramural, and extramural, and this one is the intraluminal, typical intraluminal cause of mechanical intestinal obstruction. Now the name is Gallstone Ileus. So thanks a lot for watching, and we'll come on the next session of the InstaLecture on a newer topic. Thank you very much.